Okay, we'll start with the reproductive system today. The reproductive system is the only system that's not essential for life. I think I made that statement before in some of the earlier lectures. Probably the first lecture we talked about the systems and how they all work together. It's not that the reproductive system isn't important, but it's not essential for sustaining life. So none of the other systems in our body, the nervous system, the cardiovascular system, none of our other systems are dependent upon the reproductive system. Now, that's not true for the reproductive system. It is, in turn, dependent upon some of the other systems, not only the nervous system, cardiovascular system, but the endocrine system. All of the other systems in the body are important to carry on the reproductive system, but it, in turn, does not reciprocate those characteristics to other systems. So it ensures the existence of the human species. Obviously, when we talk about the continuation of our species, the sexual mature male and the female will produce individual reproductive cells that are brought together in a sexual act. Then these cells will fuse, and it starts a chain of events that leads to infant, which will then mature and develop over time. The human reproductive system produces and stores nourishments, and it transports functional male and female reproductive cells. These reproductive cells are referred to as gametes. Fertilization is known as conception, in which the male gamete and the female gamete will unite. And all the cells in the human body are the mitotic descendants of a zygote, which is basically a single cell created by the fusion of gametes from the father and the mother. In the process of development, we see a gradual transformation from a single cell into a functional adult, which obviously are millions of cells, spans over 15 to 20 years of development. And this process is thus referred to as human development. Now, during these periods, there are hormones that also will cause effects in the development of these developing cells. Hormones produced by the reproductive system tend to direct the gender-specific pattern of development. We'll talk a lot more about some of the hormones that are involved in this process as well. Now, some of the components, gonads or reproductive organs that produce gametes or hormones. There are ducts that receive and transport the gametes through the reproductive tracts, respectively, in both males and females. We'll talk about those more. There are accessory glands and organs that secrete different types of fluids, whether the fluids are for lubrication or whether they're for to fight off bacteria, or whether they are important in the transport mechanism of these developing cells. You'll see that there are a number of accessory glands in both the male and female reproductive systems. Then there are perineal structures, which collectively are known as external genitalia, which also perform a role in reproduction. Male and female reproductive systems are functionally quite different. In the adult male, you see testicles, male gonads. They secrete sexual hormones such as androgens, principally testosterone, which many of you may be familiar with. Testosterone is the most important, or one of the most important hormones in the male reproductive system, which is introduced together with other sexual hormones as well. And we'll talk about some of those other hormones that are a part of the endocrine system and how they play a role in the male reproductive system and in the female reproductive system. The testes also produce male gametes called spermatozoa or sperm, 1/2 billion each day. It's a lot of sperm. Male reproductive systems during emission, mature spermatozoa will then travel the length of the ductal system in the male reproductive system, where they will mix with secretions and accessory glands that are along the tract of the ductal system in the male reproductive system. The mixture of the secretions along with the spermatozoa is referred to as semen. During ejaculation, the semen is expelled from the body of the male, typically into the female, and then there will be a union of the gametes, and we'll go into more detail about that in just a bit. In adult females, the reproductive system is composed of ovaries, gonads, typically will release one immature gamete or an oocyte per month. The immature oocyte will then travel, or immature gamete thus will then travel through a short ductal system referred to as the uterine tubes. At the end of the uterine tubes is a large muscular structure, a central structure referred to as the uterus, sometimes commonly called the womb. When the sperm reaches the oocyte and initiates the process of fertilization, we see the oocyte will mature into what's referred to as an ovum. A short passageway in the female reproductive system, referred to as the vagina, connects with the uterus with the exterior environment. During sexual intercourse, the ejaculant then is introduced semen into the vagina, and then the spermatozoa will ascend through the female reproductive tract. Now, fertilization occurs if the two gametes are going to join. Fertilization occurs, the uterus will then enclose and support a developing embryo. Now the two gametes, one from the male and female, have united and will develop an embryo. As the embryo grows into a fetus and prepares for birth. Now, important point here is that the male reproductive system is only involved in the fertilization portion of this. Development is the role of the female reproductive system. So not only is fertilization a part of the female reproductive system, but also development as well. This is the male reproductive system. Again, you'll see that the reproductive system in both male and female serve a dual role, not only in reproduction, but also some of the passageways are common with the urinary system as well. I know we didn't go into a lot about the urinary system in this part of A&P, but next semester, those of you who take A&P 2 will go into a lot more detail about the urinary system. But as you can see, some of the structures, and you'll have to identify these in the lab, the positioning of the testicles, another structure referred to as the epididymis, which we'll go into detail about the role and function of both of these structures. The ductal system, which includes the ductus deferens. This is where mature sperm will then travel through a ductal system, will pass through a series of areas where additional secretions will enter into this ductal system. The seminal vessels will supply some of those secretions. The prostate gland will also supply some secretions. And then a common passageway here for both the urinary system and for the reproductive system, the urethra. There is different portions of the urethra. There is the penile portion of the urethra, and then the external urethral meatus, which is the opening to the external environment. But both urine and semen can pass through this ductal system to the external environment. Proceeding from the testes, spermatozoa travels through the epididymis, the ductus deferens or the vas deferens. Your book, I think, uses both names interchangeably. The ejaculatory duct, and then the urethra before leaving the body. I think that might be a test question, that process of follow the sperm from the epididymis or from the testicle. So you should know that basic track: epididymis, ductus deferens, or vas deferens through the ejaculatory duct, then through the urethra. There are accessory organs, seminal vesicles, prostate glands, bulbourethral glands that secrete various fluids, as I already said. They secrete these fluids into the ductal system, and which will then enter into the ejaculatory ducts and or the urethra. The external genitalia consist of a scrotum, which encloses the testicles, the penis, the erectile organ, and then through the distal portion of this structure called the urethra, and this is the route by which the semen and or the sperm will pass. Now, in the development of the male gonads, the testicles in the male during development, usually at about the 7th month of development, the testicles are actually still in the abdominal cavity. There's a process referred to as the descent of the testicles. In other words, the testicles actually have to migrate from an intra-abdominal location into the scrotum. So during the 7th month of development, fetal growth continues at a rapid pace. Circulating hormones will stimulate the contraction of the gubernaculum testicles. Over this period of time, we'll see the testicles will move from the abdominal musculature or an intra-abdominal location, accompanied by small pockets of peritoneal cavity, which will still wrap the testicles. And the process, again, is referred to as descent of the testicles. I don't know if you can appreciate. Yeah, you can. Okay, appreciate that picture. Well, but this basically shows the intra-abdominal location of the testicles, and then the testicles, after about the 7th month, will begin to descend. And at time of birth, the testicles actually have migrated from an intra-abdominal location and are in a position in the testicles, or in the scrotum. This is a much better picture, again, demonstrating to you the position of the gonads or the gubernaculum testicles, again by hormone secretion, which will stimulate the migration of the testicles. Again, they will pass down the abdominal wall to a lower position, and then at about the 7th month you can see that they're in the inguinal canal, and then by birth they should have descended into the scrotum. Now, one or both testicles that have not descended into the scrotum by the time of birth is referred to as a cryptorchid testes. Basically, that testicle is lodged in the abdominal cavity. Sometimes it can lodge within the inguinal canal as well. Occurs in about 3% of full-term deliveries, roughly about 30% of premature males. If the testicle does not descend into the scrotum, then a procedure has to be performed to remove that testicle. That procedure is referred to as an orchiectomy. Now, in most instances, normal descent occurs a few weeks later. So if it's not in the scrotum at the time of birth, hopefully it will descend, and usually physicians will wait for a period of time to see if it will migrate further after a few weeks, especially in premature infants, because infant comes out, say, a month in advance, and typically you'd give that infant probably 8 weeks or more to see whether or not the testicle will descend. And then if it doesn't, you take corrective measures. Typically, you take these measures while the male is still an infant, because if the testicle is allowed to remain in the abdominal cavity, it will not produce spermatozoa. Now, it's not that it's not producing spermatozoa because of the location. Well, it is, but all the structural components are there. But the problem is the body temperature. The reason why the testicles have to be in the scrotum is because of body temperature. Sperm won't develop at 98.6. That's our normal body temperature. Sperm has to develop at a lower temperature, and so if the testicle remains in the abdominal cavity, the body temperature is higher than what sperm needs to develop. And so if corrective measures aren't done, the testicle will not produce spermatozoa. So these individuals will be sterile or infertile and unable to bear children. Now, if the testicles are not moved into the scrotum, in most cases, they will be removed, because about 10% of males with uncorrected cryptorchid testes will also develop testicular cancer. So there's a second reason for wanting to correct this as soon as possible. Surgical procedure, again, is referred to as orchiectomy. This is an illustration of the mature male reproductive system. Some of the structures that you'll need to be familiar with and have to identify in the lab portion of the exam are listed here. You should be able to identify the testicle. You should be able to identify some of the layers of the testicle, which I'll go into in a little more detail in some later slides. The testicular artery, which supplies the blood supply. The papilliform plexus, which is the venous system that takes blood in and out of the male reproductive system. You should be able to identify the scrotal septum and the raphe. The raphe, I know there's a couple of test questions about the raphe. This is basically the partition which separates the two testicles. There is a muscle that surrounds the testicle, and actually the whole neurovascular bundle here. The muscle is called the cremaster muscle, and we'll talk about the cremaster muscle in a little bit as well. The opening from the peritoneal cavity where the testicles will descend, the inguinal ring. This is important because this is an area where hernias can occur. Even though this seals off after the testicles descend, it is still a point of communication between the scrotum and the abdominal cavity. And in cases where there is significantly increased intra-abdominal pressure, you actually can get a herniation, or intra-abdominal structures are pushed through this inguinal ring, and that's what produces a hernia. So this is the path of least resistance in the abdominal wall. So the inguinal ring is an area that you should be able to identify as well. The shaft of the penis here, and then there are some other structures that we'll go into a little more detail, internal structures, cavernosums, and erectile tissue that we'll go into in just a little bit. The spermatochord is paired structure that extends between the abdominal pelvic cavity and the testicles. Each spermatochord consists of a layer of fascia, muscles that enclose the ductus deferens, that's the ductal system that leads from the testicle to the external environment, the ductus deferens, and there are blood vessels, nerves, lymphatic vessels, again, that I showed you on the earlier picture. Each spermatochord begins in the deep inguinal ring. This is the entrance into the inguinal canal or passageway through intra-abdominal structures. There are blood vessels that include the differential artery, the testicular artery, and the pupilliform plexus, those of which I just showed you. They make up this neurovascular bundle along with the genitofemoral nerve from the lumbar plexus. Genitofemoral nerve, the lumbar plexus is just a group of nerves that come off the spinal cord. One of those nerves, the genitofemoral nerve, goes into the neurovascular bundle that innervates the male reproductive system. The inguinal canal I already referred to. This is a canal that during development, as the testicles descend into the scrotum, at that time the canal links the scrotal cavity with the peritoneal cavity, or the abdominal peritoneal cavity. In normal adult males, the inguinal canals are closed by the presence of the spermatochord, and then the fascia will then seal around that spermatochord and seal the opening. However, it is still a path of least resistance. The other path of least resistance that we see in the abdominal cavity is the umbilicus, because remember, that's a connection between the baby and the mom, and it too seals off during development. But again, sometimes with increased intra-abdominal pressure, we'll see herniations not only from the inguinal canals but also from the umbilicus as well. In males, the inguinal canal are the most common area that you see inguinal hernias, is the most common area where you see hernias. They're referred to as inguinal hernias. In females, the most common site of a hernia is the umbilicus, especially during pregnancy. Again, that increases intra-abdominal pressure. There's not a descent of the testicles in females, and so because of that, the path of least resistance in the abdominal wall for women is typically the umbilicus, and so that's a point where you can see hernias occur in women. Inguinal hernias, as a result of weakness, the inguinal hernias protrusions are a portion of the peritoneal lining or the intestines into the inguinal canal. This is relatively common in males, especially with lifting or straining, anything that makes you increase the intra-abdominal pressure. The inguinal canals in females are very small, containing only a small inguinal nerve surrounded by the ligaments of the uterus, so it's a very tiny opening, and in comparison with the umbilicus, it is not the path of least resistance, so you do not commonly see women suffer from inguinal hernias. The abdominal wall is almost completely intact, with the exception of those 3 points, the 2 inguinal rings and the umbilicus. And so again, that's why you can see herniations occur there. The scrotum is divided internally into 2 chambers. Partition between the 2 testicles is marked by a raised, thickened scrotal surface known as the raphe. The raphe separates, or is the partition between the 2 testicles. Test question. Because the scrotal cavities are separated by this partition, infection and or inflammation in one testicle typically doesn't infect or involve the second testicle as well. And that's typically, there are exceptions to that rule, but for the most part, usually if a person gets epididymitis, which is an inflammation in the gland that's close to the testicle, typically it will not infect the other testicle because of this partition. The cremaster muscle I referred to in the earlier illustration, muscle that lies deep to the dermis. Contraction of the cremaster during sexual arousal or in response to changes in temperature tenses the scrotum and pulls the testicle closer to the body. Now, sperm is temperature dependent, and the cremaster muscle helps maintain the temperature of the sperm. The body temperature is hot, the cremaster muscle will relax, the scrotum will hang further away from the body, thus decreasing the temperature in the testicle, allowing the sperm to mature. In a cold environment, the cremaster muscle contracts, pulls the testicles closer to the body, maintains the body temperature. The goal there is to try to maintain active development of spermatozoa, which is temperature dependent. In some societies, one form of birth control is for the men to take hot baths or saunas before having sexual intercourse, because it elevates the temperature of the spermatozoa, and the sperm are not viable, and so it's one method of birth control. Now, that's not 100%, wouldn't go out and promote that, but in some societies that's a form of birth control, and it's reasonably effective. The cremaster muscle, again, relaxes, contracts, moves the testicles away from or toward the body as needed to maintain acceptable testicular temperature. A sudden cooling of the scrotum that can occur when entering like cold environments, cold swimming pools, the example that your book gave, will cause contraction. Now, here's another illustration out of your textbook that just demonstrates to you some more intricate details of the ductal system. As you looked at the ductal systems inside the scrotum now, you'll see a series of ductal systems or ductal tubes that are developed here outside of the scrotum or sitting just superior to the level of the testicle is a significant layer of ductal tubes referred to as the epididymis. These are where we'll see the development or the continued development of the sperm in the system. You can see there are several layers that are part of the scrotum. The dartos muscle, which is a muscular tissue that surrounds the testicle, the superficial scrotal fascia, and again, we've already talked about the cremaster muscle. There are layers that cover the deeper structures, the tunica vaginalis, the tunica albuginica, which are basically just tissue layers, fascial layers that surround or cover the ductal system inside the testicle. And as you can see, there are partitions here that separate the developing sperm in the ductal systems. These little septae which divide actually give a redundant system of development. Damage or injury can occur in one of these areas, but sperm development can still continue in the other areas because of the partitioning that takes place. Again, infections that occur in one area don't have to invade or infect the other areas because of the partitioning that takes place in this ductal system. These tubules that we see divided by the septae are referred to as the seminiferous tubules. Again, we'll talk about those in a little more detail during the lecture. Connective tissue in these regions to support blood vessels, lymphatic vessels, supply the testes, and the ductal tubule system, the efferent ductals, which transport spermatozoa to the epididymis. And this picture shows you where the seminiferous vesicles will all go into a common area referred to as the rete testes, and then the developing sperm will then enter into the head of the epididymis, which you see sits in a posterior superior position on the testicles. And then again, the ductal system of the epididymis will extend and lead into the ductus deferens, where the sperm will then travel, as we already talked about, through the urethra and outside the body. So it's a significant developmental system here. These areas are a continued process, completely different from the development as we'll see in the female reproductive system, which we'll talk about in more detail. So structures here you need to be familiar with. Again, the spermatochord, which is the combination of not only the artery and the vein and the nervous system and the lymphatic vessels, but also the vas deferens, the epididymis, again, which sits in a superior posterior position in relationship to the testes, the seminiferous vesicles, and then the rete testes. And then the layers, again, the tunica albuginica, the tunica vaginalis, which I showed you on the preceding picture here as well. The epididymis, this is the start of the male reproductive tract. Coiled tubes bound to the posterior border of the testes. Epididymis is coiled and twisted, takes up very little space. It has a head, a body, and a tail. The functions of the epididymis, I think there's a test question on this, monitors and adjusts the composition of fluid produced by the seminiferous vesicles, acts as a recycling center for damaged spermatozoa. It stores, protects spermatozoa, and facilitates their functional maturation. There is a term that you should be familiar with referred to as capacitation. This is when the sperm becomes mobile or motile. It's actively swimming. It's very functional at this point. Spermatozoa must undergo this process of capacitation. Two steps of the capacitation includes it becomes motile, when it's mixed with secretions from the seminal vesicles, they become capable of successful fertilization when exposed to conditions in the female reproductive tract. Now, another term that you should be familiar with is peristalsis. Peristalsis is contraction of the smooth muscles in the ductal system, both in the male and female reproductive system. Smooth muscles have to contract as sperm moves through the ductal system. The smooth muscles in the vas deferens actually squeeze, and they push the sperm through the tract. Now, there's some other characteristics or structures that assist in the movement of sperm as well. But one of the functions, though, is peristalsis. This is the contraction of smooth muscle, and it's in a wave-like pattern that helps to move sperm along the reproductive system. This same mechanism, peristalsis, is also in the female reproductive system. We commonly talk about peristalsis in the digestive system, and again, next semester, if you take A&P2, you'll see in the digestive system we talk about peristalsis, and it's the contraction of smooth muscles that starts in the esophagus. When we swallow food, peristalsis occurs. The esophagus will squeeze and push food through our digestive system. The stomach has peristalsis. The large and small bowel first, and the large bowel have peristalsis as well to help move food through our system and then to help move waste through our system as well. So peristalsis is a contraction of smooth muscle. You should be familiar with that term. So the transport through the epididymis involves combination of fluid movement and peristaltic contractions of smooth muscles in the wall of the epididymis. After passing along the tail of the epididymis, the spermatozoa then enters the ductus deferens. Another up close and in person illustration here of the reproductive system. As you can see, the vas deferens will then pass the sperm into what's referred to as the ampulla of the ductus deferens before it enters into the passageway, common passageway of the urinary system. Again, there's a common structure here, the urethra, which will pass both urine and the products of the male reproductive system. And so we'll see that common passageway will join here at the prostate gland. You should be familiar with the prostate gland in its location. And then the seminal vesicle, and again, it's responsible for providing secretions in the maturation process as well. The location of the urinary bladder. Now, a procedure that can be done in males to ligate the vas deferens can lead to infertility in males. Surgical procedure, basically where these small tubes are basically cut, ligated, tied off, and burned. You have to do it on both sides, otherwise it's not effective. But you have to basically cut this lumen, block this lumen to prevent sperm from being able to travel. This is an outpatient procedure that can be done on males that can lead to infertility or sterilization. And again, it's the ligation of the vas deferens, and again, it should be tied, burned, and cut for that procedure to work. The ductus deferens, each ductus deferens or vas deferens is about 16 to 18 inches long, begins at the tail of the epididymis, then a part of the spermatocoid, and ascends through the inguinal canal. The function of the ductus deferens or the vas deferens, in addition to transporting spermatozoa, it also can store spermatozoa for several months. During this time, the spermatozoa remains in a low state of suspended animation, has a low metabolic rate, and so its requirements are not that high, and so it can be suspended in that area for a period of time. The urethra, we've already alluded to on several occasions. Urethra extends about 7 to 8 inches from the urinary bladder to the tip of the penis. It is divided into a prostatic, membranous, and penile region, all urethras. The male urethra is the passageway used both commonly for the urinary and the reproductive system. Accessory glands include, and we'll talk about the prostate gland, the bulbourethral gland, and the seminal vesicles. The fluid components of semen are basically a mixture of secretions from each of these glands, within each of which have specific chemical characteristics that provide additional support for the maturing sperm and or the mobility of the sperm. Important glands, again, prostate gland, bulbourethral gland, and the seminal vesicles. Again, another picture demonstrating to you, illustration out of your book, the various glands that are involved in this process. The seminal vesicles, the prostate gland we've already talked about, and the bulbourethral glands and where they're located at inferior to the urinary bladder. Some other structures that we're going to talk about in just a minute are the erectile tissues of the penis. This includes the corpora cavernosum. As you can see, a central artery kind of sits through that, and then the urethra passes, as you can see, on the anterior surface. Now remember, in anatomical position, the male penis is up, so the back of the penis is actually the front of the penis. So the urethra actually sits in the anterior surface. So remember, when we talk and we ask about anatomical locations, remember what the anatomical position is when identifying certain structures. Thus, the blood vessels are on the dorsal surface, or again, if the penis is sitting up, the dorsal surface is actually the side that would be next to the abdominal wall. And so the vessels that course on that side are referred to as the dorsal blood vessels, and you can see, if I can get my arrow to work, two arteries that are located here, and then there are also veins, and these are actually nerves that here, always there's going to be a neurovascular bundle. What's not shown are the lymphatic vessels that course here as well. But as you can see, through the corpus cavernosum are arteries, central arteries that pass. The corpus cavernosum, and we'll talk about this in just a little bit, is the area that engorges with blood during an erection. It spills up with venous blood and enlarges the male penis prior to sexual intercourse. Some other structures that are important: the head of the penis, the glans penis. This is a circumcised male penis that we're looking at here in the picture. There can be a prepuce or foreskin that would cover up the glans penis that would have to be pulled back or retracted to be able to fully visualize it. The body or the shaft of the penis, again, the structures here that you see now, this is in cross section below, gross anatomically. The corpus spongiosum, which actually lies on the ventral surface, and again the blood vessels, which would lie on the dorsal surface of the male penis. The scrotum we've already talked about in these structures. Major functions of the glands: activating spermatozoa, providing nutrients for spermatozoa, propelling spermatozoa and fluids along the reproductive tract, mainly by peristaltic contractions, which we've already talked about, and producing buffering or counteract the acidity in the urethra of the vaginal environment. Vaginal environment is acidic. For the sperm to survive, has to have some buffers to counteract the acidity that is in the female vagina. Seminal vesicles are glands that are embedded into connective tissue on either side of the midline, sandwiched between posterior wall of the urinary bladder. Seminal vesicles contribute about 60% of the volume in semen, and although the vesicular fluid generally has the same osmotic concentration of that of blood and plasma, the composition of the fluids are very different. Higher concentrations of fructose, I think that's a test question, which is essential to the metabolism of the spermatozoa. It's an energy source. Fructose. Prostaglandins, which stimulate smooth muscle contractions along the male and female reproductive tract. Fibrinogen, which after ejaculants form a temporary clot within the vagina. And we'll talk about like a semen analysis, but fibrinogen is important because the ejaculant forms a temporary clot inside the vagina. Then the pH of the vagina and some other biochemical reactions will take place, and this clot of ejaculant will eventually dissolve, and the sperm will be released to be able to swim free. Secretions in the seminal vesicles are slightly alkaline, helping to neutralize the acids, secretions of the prostate gland and within the vagina. So it's important that an alkaline median be established. Now, the sympathetic nervous system, and should be parasympathetic nervous system here, the secretions of the seminal vesicles are discharged into an ejaculatory duct when peristaltic contractions are underway in the ductus deferens, seminal vesicles, and the prostate gland. These contractions are under control of both the sympathetic and parasympathetic, and the parasympathetic actually dominates. I don't know why I titled that sympathetic. In the prostate gland is a small muscular rounded organ about 4 centimeters in diameter. Prostate gland encircles the proximal portion of the urethra as it leaves the urinary bladder. It produces prostatic fluid, slightly acidic. Solution contributes about 20-30% of the volume of the semen. In addition to several other compounds of uncertain significance, the prostatic secretions referred to as seminoplasmin. Seminoplasmin basically is an antibiotic or an antibiotic of sort that may help prevent urinary tract infections in males. Males have a couple of advantages in the structure of the urethra because the urethra in the male is longer than the urethra in the female. Now I'm talking about the urethra, I'm not talking about penile length, and that's common confusion. The urethra of the male is longer than in the female. Because of that, bacterial infections, for bacteria to become bladder infections, has to migrate up the urethra. Bacteria migrates a bit, but it also goes through growth phases. And so as the bacteria grows and it doubles in the number of bacteria, the growth cycle allows the bacteria to migrate into the bladder. Because the male urethra is longer, typically the male has an opportunity to urinate and then will wash the bacteria out of the urethra before it can migrate into the bladder and cause an infection. In the female urethra, and we'll show that when we do the female reproductive system in just next few slides, we should start that up, you will see that the urethra is short. And so one growth cycle, the bacteria is already in the bladder. So women tend to have a more frequent urinary tract infections than males. Now, on occasion, males can have urinary tract infections as well. Typically, when you see it in males, it's related to prostatitis. The prostate gland will swell, and when it swells and the bladder contracts and attempts to push urine through that swollen prostate gland, when the bladder relaxes, sort of like drawing a plunger back. And as the bladder relaxes, it actually pulls urine from the urethra back into the bladder. And so you get urethral reflux. And when that occurs, if bacteria is in the distal portion of the urethra, now you pull the bacteria into the bladder. And so men can develop urinary tract infections. Typically, you'll see that associated with enlargement of prostate gland and or prostatitis. Prostatitis is basically prostatic inflammation. The itis means inflammation. Occurs in males at any age, but most commonly afflicts older males. Can result from bacterial infections, but also can occur in the apparent absence of pathogens. Symptoms resemble that of prostate cancer, difficulty with urination, may see blood in the urine, may have a degree of pain. Because of the location of the prostate gland, which is close proximity to the rectum, person may also have pain when they move their bowels, may not be able to move their bowels because of prostatic inflammation, so it's a painful condition. In some cases, accompanied by painful urination, discharge of mucus from the external urethra. Antibiotic therapy is typically effective in treating this bacterial infection. Another gland we'll talk about briefly is the bulbourethral gland. You saw its position just inferior to the prostate gland. It's a pair of glands located on each side of the urethra, and again inferior to the prostate gland, situated at the base of the penis, covered by a fascia, the urogenital diaphragm you're familiar with already. The bulbourethral glands are round in diameter, approaching less than 0.5 inches. The ducts of each of the glands travel alongside the penile urethra before emptying into the urethral lumen. The glands produce a secretion that helps neutralize any urinary acid that may remain in the urethra and lubricates the glands and the tip of the penis. Each of the glands travels alongside the urethra, again produces an alkaline mucus, and again neutralizes the acidic environment from the urine, but also the secretions. If the semen enters into the female vagina, will also help neutralize the acidic environment in the vagina as well. Now, semen ejaculant, typically at an ejaculant, it releases about 2 to 5 cc's or 2 to 5 milliliters. Milliliters, cc's the same, you guys already know that. 2 to 5 cc's of semen in an ejaculant. The ejaculant contains typically spermatozoa, the seminal fluids, and also some enzymes. The normal sperm ranges from 20 million to 100 million spermatozoa per cc of sperm. You need to know those numbers, 20 million to 100 million spermatozoa per cc, and so we got 2 to 5 cc's of sperm. Fluid components of the semen is a mixture of glandular secretions, distinct ionic and nutrient composition. Typical sample of seminal fluid contains a combined secretion of seminal vesicles, about 60%, prostatic gland about 30%, substanacular cells and epididymis about 5%. Don't need to know all these percentages, just to give you some idea. And the bulbourethral gland, less than about 5% contributes to the semen. A protease, which will help dissolve the mucus secretions in the vagina. Protease is basically an enzyme. Seminoplasmin, we already talked about. Seminoplasmin is basically an antibiotic of sorts. It's an antibiotic enzyme from the prostate gland that will help kill bacteria, including E. coli, which is a common cause of urinary tract infections. Prostatatic enzymes also convert fibrinogen to fibrin after ejaculation. Then there's fibrolysin, which will subsequently liquefy the clotted semen. So when semen comes out, typically it's clotted, gel, and then there's fibrolysin, which will help break down the ejaculant into a liquefied state so the sperm can swim free. Now, in a semen analysis, it's common to perform in males to assess fertility. A sample of semen is donated after 36 hours of a period of abstinence. And typically these would be the characteristics that you look at. This is the test question. Characteristics include mobility, shape, liquefaction. Basically what you look at is 60% of the sperm in any sample have to have beating flagella, have to be actively swimming. That's one component in a semen analysis. The other thing is the shape. 60% of the spermatozoa should have normal shape. Common abnormalities such as malformed head, twinned spermatozoa, which do not separate, would be a factor as well. So 60% have to have normal characteristics. And then liquefaction, which is basically the work of fibrinolysin, which within a few minutes of the ejaculant, the semen coagulates, then liquefies again at sometimes later. Normal semen liquefies in about 15 to 30 minutes. An extended liquefaction time actually indicates a problem in the secretion of some of the accessory glands. So those characteristics must be intact for normal sperm to be able to fertilize the female egg. The other constituent would be the volume. Normal ejaculant measures about 2 to 5 cc's. And then the sperm count. Each ejaculant should contain more than 60 million sperm. Concentrations of spermatozoa should be 20 million per cc of semen. Most individuals with lower sperm counts are infertile because too few sperm can't survive the ascent of the female reproductive tract performed in fertilization. Low sperm count may reflect inflammation in the epididymis, the ductus deferens, the prostate gland. Any of those glands can be involved in decreasing the total sperm count and or the volume and or the other factors that I talked about earlier. So these are some of the components, 5 key components that you look at in semen analysis. I'm almost sure that's a test question. External genitalia. The male external genitalia consists of a scrotum, penis. Penis is a tubular organ through which the distal portion of the urethra passes, conducts urine in the it conducts urine to the external environment and introduces semen into the female vagina during sexual intercourse. Penis is divided into 3 regions: the root, the body, and the glands. The root of the penis, fixed portion that attaches the penis to the body wall. This connection occurs within the urogenital triangle immediately inferior to the pubis symphysis. And again, you remember that when you studied the skeletal system. The body, or the shaft of the penis, is a tubular, movable portion of the organ. The glans penis is an expanded distal end which is surrounded by the external urethral meatus. The prepuce are a fold of skin called the prepuce, or the foreskin, surrounds the tip of the penis. In uncircumcised male, the prepuce attaches to a relatively narrow neck of the penis and continues over the glans. I like this part. Smegma. This is a gland in the portion of the skin in the inner surface of the prepuce that secretes a waxy material referred to as smegma. Smegma can be an excellent nutrient source for bacteria. You see this in uncircumcised males. with poor hygiene, an accumulation of wax under the foreskin. And so the foreskin actually covers the head of the penis or the glans penis, and you pull back the foreskin or the prepuce, and this waxy material with bacteria has kind of developed over time. It can cause mild inflammation, infection in this region, and the area has to be washed effectively, thoroughly, and then sometimes antibiotic ointment would have to be applied to be able to treat that condition. The condition itself, and I thought I had the word on here, is called ballantitis, but it's basically accumulation of smegma has occurred. This waxy secretion has occurred under the prepuce around the glans penis, and it leads to significant inflammation and infection in that region. And so to avoid that, circumcision obviously at infancy, but an adult male going through circumcision, a little more complicated surgery. But so if somebody calls you smegma, it's not a term of affection, trust me. Prostatic hypertrophy basically is the enlargement of the prostate gland, occurs spontaneously in men over the age of 50. Increase in the size occurs while testosterone production in the interstitial cells will basically decrease. Small masses occur in the prostate gland referred to as prostatic concretions, which may form within the glands. Interstitial cells begin releasing small quantities of estrogen into the bloodstream. Combination of lower testosterone levels and the presence of estrogen, yes, estrogen in males, probably stimulates the prostatic growth, causes enlargement of the prostate gland, which can lead to problems. Severe prostatic hypertrophy, swelling constricts and blocks the urethra. Remember, the urethra passes through the prostate gland. It's not corrected. The urinary obstruction can cause permanent kidney damage, certainly can cause enlargement in the ductal system leading from the kidneys. There are ureters, and there is a portion of the kidneys called the calyces. Don't have to know about that right now, but basically will swell and dilate and cause significant dysfunction in the kidneys. So partial surgical removal is the most effective treatment. Procedure is known as a TURP, or transurethral prostatectomy, basically where the opening of the prostate gland is opened or widened. An instrument basically is pushed through the urethra and opens and dilates the urethra, and thus shaving off the inner portions of the prostate gland. Now, prostate cancer is a malignant metastasizing type cancer. Metastasizing just basically means the cancer can spread related to the prostate gland. Second most common cancer and the second most common cause of cancer deaths in males. I'll pause it just for a second now. Second most common cancer, and then it's reported as the second most common cause of cancer deaths in males. Recognize this is a cancer of older males. And so prostate cancer is a very treatable cancer, and yes, it does metastasize, but it's a very treatable cancer. But because the population that we're dealing with here is an older population, usually seventh decade of life, then many of the individuals that die with the diagnosis of prostate cancer probably died from other causes, but there's been no study to really closely look at that. Last numbers I have, I think your book reported, was 2002, approximately 189,000 new cases of prostate cancer diagnosed in the United States each year, 30,000 deaths from the ailment. Most patients are elderly. Again, there's some comorbid conditions, other illnesses also in this population, and because it's an older population, I think prostate cancer probably gets higher numbers than it really is accounted for. Prostate cancer normally originates in one of the secretory glands. As the cancer progresses, it produces a nodular lump or a swelling in the surface of the prostate gland. Palpation of this gland through the rectal wall. Remember where the prostate gland sits at, inferior to the bladder. Bulbourethral glands sit inferior to the prostate gland. Posterior to the prostate gland is the rectum. And so usually about 4 inches of palpation. So if the finger is inserted into the rectum, you can easily palpate the prostate gland. You can determine if the prostate gland is nodular. You can determine whether or not it's tender or not. So the rectal examination is still an important diagnostic tool in being able to identify the characteristics of the prostate gland. Palpation of this gland through the rectal wall, procedure known as a digital exam, is the easiest diagnostic screening procedure. There's also blood tests that can be done as well, prostatic specific antigen, also known as PSA. I'm sure that's a test question. Most sensitive blood test. Elevated levels of antigens normally are present in low concentrations would indicate the presence of prostate gland. So if the PSA is elevated, gives you a good idea that something's going on in the prostate gland. Now, inflammation, prostatitis, can also cause an elevation in the PSA. So if you have just inflammation, you may have an elevated PSA as well. However, if the number is significantly high and continues to elevate over time, it's a good indicator that the person probably has a prostate cancer. Serum enzyme assays, which check the levels of isoenzymes of prostatic acid phosphatase, detects prostate cancer in its later stages. Basically just an enzyme that's released in this process, can also be measured. This is in the later stages though. For screening, the most sensitive test is the PSA. Screening periodic PSAs are now being recommended for men over the age of 50. Prostatectomy, condition detected before the cancer cells can spread to other organs. Usual treatment, localized radiation or surgical removal of the prostate gland. Operation prostatectomy can be effective in controlling condition, but surgery and radiation can have undesirable effects, including urinary incontinence and loss of sexual function. Metastatic prostate cancer prognosis is much worse for prostate cancer diagnosed after metastasis. Diagnosed it after metastasis has occurred, the prognosis is poor. Metastasis occurs rapidly because the lymphatic system, where every time you see blood vessels, and this is a very vascular area, every time you see blood vessels, you see lymphatic vessels. If there's a cancer that develops there, the cancer can migrate into the lymphatic system and quickly spread throughout the system. So you'll see quickly involvement in the lungs, the bone marrow, the liver, and the adrenal glands can be involved as well. Survival rate at this stage is relatively low. Now remember, we're saying diagnosis at the time already had metastasis. Okay, if you screen PSA and you catch it early, it's a very treatable cancer. But if you don't diagnose it early and it's diagnosed after it's metastasized, these are some of the things that you'll see. Treatment for metastatic or metastasized prostate cancer include widespread irradiation, hormonal manipulation, lymph node removal, and aggressive chemotherapy. Chemical castration, cancer cells are stimulated by testosterone. Treatment may involve chemical castration or by giving gonadotropin-releasing hormone, which we'll talk about a little bit here later, or luteinizing hormone to suppress the production of testosterone. Another treatment option is estrogen. Dilestobestol is an agent that's used. Basically, it's a second drug. It mimics gonadotropin-releasing hormone. These drugs are given in high doses and produces surges of luteinizing hormone. Again, we'll talk about all these hormones in just a little bit. Production followed by a sharp decline in very low levels, presumably from the endocrine cells, which will adapt from this stimulation. A third drug that blocks the action of androgens, finasteride, it prevents the stimulation of cancer cells by testosterone as well. Now, FSH and LH, the anterior lobe of the pituitary gland. Anterior lobe of the pituitary gland releases two hormones of importance, the follicle-stimulating hormone, FSH, and the luteinizing hormone, LH. The pituitary releases these hormones, occurs in the presence of the gonadotropin-releasing hormone. Okay, so this basically in the presence of gonadotropin-releasing hormones, a peptide that's synthesized in the hypothalamus and is carried to the anterior lobe of the pituitary gland by a circulatory system that's in that gland referred to as the portal system. So again, anterior lobe of the pituitary gland produces two hormones, follicle-stimulating hormones and the luteinizing hormone. This shows you the structure, and if you learn this table, you'll be able to identify what the hormonal process is in the male reproductive system. I also have a similar table for the female reproductive system. The hypothalamus releases gonadotropin releasing hormone. This in turn will come and stimulate the anterior portion of the pituitary gland. You'll see secretion of luteinizing hormone, secretion of follicle-stimulating hormone, and then when we get to the testicles, so now we're at 3 organs, hypothalamus, anterior pituitary. Third organ now is the testes. We'll see luteinizing hormone will stimulate the interstitial cells, which will in turn secrete testosterone. Follicle-stimulating hormone affects the seminiferous vesicles. Remember, seminiferous vesicles were inside the testicles in those little compartments that were sectioned off. The substenacular cells, which will synthesize androgen-binding proteins, which are important in the development and maturation of sperm. This stimulates spermatogenesis and spermiogenesis, parts of meiosis, which we'll have, if we have time today, we'll go into. But these are the hormones that are important. Now, when we see the secretion of follicle-stimulating hormone and its effect on the seminiferous vesicles and then the substenacular cells, they will also produce a substance called inhibin. And this is where that process of negative feedback that we talked about the first couple of lectures, negative feedback takes place. Inhibin will feed back and turn off the production of follicle-stimulating hormone. And so this is a negative feedback mechanism. You also see a similar mechanism take place on when the luteinizing hormone is released and the interstitial cells produce testosterone. There is a negative feedback mechanism that actually goes all the way back to the hypothalamus and turns off the hypothalamus. And so this is how the body regulates hormonal the hormones that are secreted in this process of development. So again, negative feedback mechanisms based on inhibin produced by the substenacular cells and also by the feedback mechanism from testosterone. Again, 2 hormones, anterior pituitary, luteinizing, follicle-stimulating, and from the hypothalamus. FSH in men targets primarily the substenacular cells in the seminiferous vesicles. Under follicle-stimulating hormone or under FSH stimulation, the presence of testosterone from interstitial cells will promote spermatogenesis and spermiogenesis and will secrete androgen-binding proteins. Testosterone, which is the most important androgen, has numerous functions such as stimulating spermatogenesis and promoting the functional maturation of sperm or spermatozoa through the effects of the cells there, the substenacular cells. It also affects the central nervous system, including libido and or sexual drive or related behaviors. So testosterone, most important androgen, and these are its functions and effects. Also, we see stimulating metabolism throughout the body, especially pathways concerned with protein synthesis, establishing and maintaining sexual secondary characteristics such as distribution of facial hair, increased muscle mass, body size, and quantity and location and characteristics of adipose tissue and deposits, and maintaining the accessory glands of organs in the male reproductive tract. There are some primary androgens that are secreted in the adrenal gland. Now, adrenal gland are 2 little glands that sit on top of the kidneys that also provide some additional substances that we see. Again, there are other systems affect, and the adrenal glands are part of the endocrine system, will affect the reproductive system. Secreted in small amounts is converted to testosterone and estrogens by other tissue. The significance of the small adrenal androgen contributions in both gender remain uncertain, and in some people it's suggested that this substance, dihydroxyandrosterone, DHEA, the other term, could be used to treat a variety of conditions including diabetes, heart disease, and depression. Unfortunately, because remember, androgens increase muscle mass, unfortunately because of that, we see that these drugs are sometimes abused for sports enhancement. Long-term effects of DHEA effects, high dosages still remain relatively unknown, but it is thought that it will increase the muscular development in individuals. So high levels of DHEA in women have been linked to increased risk of ovarian cancer as well as masculinization due to conversion of DHEA to testosterone. And so thus it's banned by the most professional sports and international athletic committees, NCAA, NFL, all those, football, baseball still hasn't bought in. I'm just kidding. DHEA is promoted as a wonder drug to increase vitality, strength, muscle mass. You can get it over the border very easily now. Claims are basically false about some of the drugs that are placed in some of the supplements to help increase muscle mass. So it's one to be cautious about and to watch out for as far as being an abused substance. Current recommendations are DHEA should be used and should be restricted. Supervised clinical trials. No one under the age of 40 can use the drug. And now the female reproductive system. Much more impressive than the male reproductive system. Again, the male reproductive system is only involved in the fertilization process, is not involved in development. You guys want to take a 5-minute break? Bathroom break? Yeah, we'll keep going. No? Anybody need a break? No? Okay, I'll keep going. Female reproductive system. Maybe we can finish a little early. Female reproductive system. Gross anatomical picture illustration that you'll have to identify some of these structures for your lab portion. Some key structures, and I have several illustrations here. Key structures include the ovaries and the uterine tube, if I can get my arrow to work. The ovaries, the uterine tube, the central structure here. Again, this is the uterus, sometimes referred to as the womb. There are several layers of the uterus that you need to be familiar with: myometrium, perimetrium, endometrium. Notice that the location of the uterus and its proximity to the urinary bladder. As you can see, the bladder is a little more anterior and sits a little inferior to the uterus. The location of the urethra as it passes from the urinary bladder. Now, note that the urethra here, unlike in the male reproductive system where we saw a common relationship between the urethra in the male and the reproductive system, we do not see that commonality in the female reproductive system. This is mutually exclusive. The vagina is the opening through which reproductive process will take place with the external environment, not the external urethral meatus as we saw in the male. The opening of the vagina leads to the opening of the uterus, which is the cervix. And then the proximity here, and I should have showed you this proximity with the male, but the proximity of the rectum to the reproductive structures is important to note as well. There are also accessory glands, as we saw in the male reproductive system. There are accessory glands in the female. You see the periurethral glands. There's a Bartholin's gland, vestibular glands as well that are important in the reproductive system, and we'll talk about that a little bit more in detail. Women's reproductive system produces sex hormones. Functional gametes also must be able to protect and support the developing embryo and to nourish the newborn infant. Principal organs in the female reproductive system are ovaries, uterine tubes, uterus, the vagina, components of the external genitalia. The ovaries, uterine tubes, and uterus are enclosed within an extensive mesentery known as the broad ligament, which I'll show you in an illustration coming up. Several other ligaments assist the broad ligament in supporting and stabilizing the position of the uterus associated with reproductive organs. Other ligaments lie within the mesenteric sheet of the broad ligament and are connected to the ovaries and the uterus. The broad ligament limits the side-to-side movement and rotation of the ligaments described in the discussion of the ovaries and the uterus, and we'll talk about that in just a little bit. It prevents superior and inferior movement of the ovaries to a degree. And I'll go through the process of pelvic examination, and you'll see how the ligaments do have a degree of flexibility and laxity, so though the broad ligament does help prevent significant side-to-side movement and rotation, you can still have a little bit there. And this illustration illustrates to you the positioning of this of the reproductive structures in the female. The ovaries are location. You should be able to recognize the ovaries, should be able to identify the uterine tube, should be able to identify the uterus, and you should be able to identify the cervix. And during a pelvic examination, typically a speculum is used to open up the vaginal walls, and then you visualize the cervix. And so during a pelvic examination, grossly what you want to be able to identify is the cervix, to be able to identify the architecture here. Sometimes the cervix can be inflamed or irritated, which would denote either inflammation, or it may denote early changes that would be consistent with development of a cancer. And so it's one of the reasons why it's important to do the pap smear. But a sample is typically taken from the cervix. There's a speculum that's used to take just some superficial cells from the lip of the cervix. And then the second part of the examination is the insertion of a small brush to the inside of the uterus. When you insert the brush into the center of the uterus, you rotate it, you're taking a little sample of cells from the endometrial lining inside the uterus, and then you take that sample out, you send those cells, you look at that under a microscope, and then the next portion of the exam is to attempt to palpate the ovaries. And this is the most difficult portion of the exam because you see the position of the ovaries here on the picture. Now remember, the extent of the fingers is going to be about 3 inches, on the most about 4 inches. So the maneuver is to try to insert and recognize the position of the ovaries. This is not through the uterus. You actually have to push the vaginal walls laterally, and you attempt to press down on the abdomen of the female patient and push the ovaries to a position where the fingers can reach, because this position is actually more than 3 to 4 inches away from the opening of the vagina. So you actually get the patient to take a deep breath in, deep breath out, and as they're breathing out, you push down, and your attempt is to try to push the ovaries down to the point where the fingers can extend, and you attempt to palpate the ovaries. Now, the broad ligament hopefully will keep the ovaries in this position, but the ovaries didn't read the book, nor did the ovaries see this picture, because the ovaries can actually flip and sit a little more superior. They can also rotate and sit a little more posterior. So on this exam, it's sometimes very difficult to try to palpate the ovaries. That's why you see ovarian cancers will progress significantly before they're identified. Because of their location, because of the location of the ovaries can enlarge significantly. Ovarian cysts can get extremely large because the position where the ovaries are sitting at makes it difficult to evaluate them. You cannot see them grossly on an exam, so when using the speculum, you only see the cervix. You can't visualize the ovary. You can't typically palpate the ovaries through the abdominal wall, and so it takes an aggressive maneuver to try to palpate the ovaries, and so that's why a lot of times ovarian cancers are missed. The best diagnostic screening tool for the ovaries is basically an abdominal or pelvic ultrasound to be able to identify it. So we'll talk about ovarian cancers in just a little bit. But these are just some of the structures. You should be able to identify the broad ligament. You should be able to identify the uterosacral ligament, the ureters as they come down from the urinary bladder, their location, the vagina, the cervix, the cervical os, which is the opening of the cervix. And again, I think I already talked about the fallopian tubes. And then you can see other ligaments that are attached to the broad ligament. One of the ligaments is the ovarian ligament, which will attach the ovaries to the body wall of the uterus. And then the suspensory ligament, which you'll see will attach the ovaries to lateral body wall structures. The infundibulum, which is basically little finger-like projections that extend from the fallopian tubes, should be able to identify these structures. Again, we already talked about the ovaries. Paired ovaries, small, lumpy, almond-shaped organs in the lateral wall of the pelvic cavity. Main functions of the ovaries: produce immature female gametes or oocytes, secrete female sex hormones including estrogen, progesterone. They secrete inhibin. And the feedback mechanism that I talked about earlier for the males, you can see that you also see inhibin, which will produce a feedback mechanism to control pituitary secretion of follicle-stimulating hormone. Oogenesis, the ovum production or oogenesis begins before a woman's birth and accelerates at puberty. Between puberty and menopause, oogenesis occurs monthly basis as a part of the ovarian cycle. Oogonia, stem cells of the female complete their mitotic division before birth. Between the 3rd and 7th month of fetal development, the daughter cells are the primary oocytes prepared to undergo meiosis. They produce as far as prophase of meiosis 1, but at that time the process comes to a halt. I won't go into a lot of detail about meiosis today. I did put 2 PowerPoints on to go through meiosis in the male reproductive system and meiosis in the female reproductive system. So review those, but I'm not going to go into a lot of detail about it. I do want you to know the difference between mitosis and meiosis. Mitosis we see occurring in somatic cells, right? Meiosis we see that take place in the gametes or the sex cells. So 2 differences. But as you recall from mitosis and some of the stages of mitosis, there was a prophase, but as you can see in meiosis it was a bit different because we'll proceed as far as prophase in meiosis, but then it will come to a halt in development. The primary oocytes or the primary eggs will then remain in a state of suspended development until individual reaches puberty, and then we'll see a rise in the follicle stimulating hormone, which will start the ovarian cycle. Each month thereafter, some of the primary oocytes will be stimulated to undergo further development. Not all the primary oocytes produced during the development will survive until puberty. The ovaries have roughly 2 million primordial follicles at birth containing a primary oocyte, but by the time of puberty that number has dropped significantly to about 400,000. The rest of these follicles will then degenerate in a process referred to as atresia. Although the nuclear event may be underway, the ovaries during meiosis are the same as those of the testes. So the process differs in some details, and again, a lot more details are in those PowerPoints if you want to go through them. But the cytoplasm in the primary oocyte is unevenly distributed during these meiotic divisions. Oogenesis produces a functional ovum, or an egg. This is the one that's potentially can be fertilized, which contains most of the original cytoplasm and 2 or 3 polar bodies, which are basically non-functional cells that will later degenerate as well. The ovary then releases a secondary oocyte rather than a mature ovum. The secondary oocyte is suspended in metaphase in meiosis 2. Meiosis will not be completed unless fertilization occurs in this process. And again, I won't go into a lot of detail about, again, but just remember, meiosis, much different process than what we saw in mitosis. Mitosis is only for somatic cells. Meiosis is the process that we see in different phases, meiosis 1 and meiosis 2, where we'll see the development of, in this case, the oocyte. The ovarian cycle can be divided into 2 phases, a follicular phase and a luteal phase. The follicular phase is referred to as the pre-ovulatory phase. The luteal phase is referred to as the post-ovulatory phase. And this is the step-by-step progression of the ovarian cycle, where you'll see the development of the egg in this process. The ovarian cycle is specialized structures which we see the oocyte growth and mature. The ovarian follicles are located in a portion of the ovary referred to as the cortex. Primary oocytes are located in the outer portion of the ovarian cortex. And then during the ovarian cycle, the process of ovulation, where we'll see the development of the secondary oocyte, corpus luteum, and then we'll see the follicle formation and a stimulation by the follicle stimulating hormone. Follicle stimulating hormone again comes from the anterior pituitary gland. The ovarian cycle begins, it is activated, and then it activates these immature, the primary follicles, to develop mature oocytes. When we see as we see the primary follicles develop over time at this stage, we see in the early development and after meiosis 1, we see the development of a secondary follicle. The primary oocyte then continues to grow at a steady pace and will rapidly become and develop into a mature follicle. About 8 to 10 days after the start of the ovarian cycle, we see the ovaries generally contain only a single secondary follicle destined for further development. And at this time, the primary oocyte has been suspended. If you recall, we talked about it being held at prophase for a period of time. And then development of a tertiary follicle will end, and luteinizing levels, and remember, luteinizing hormone also produced by the anterior pituitary gland, will prompt the completion of meiosis 1. This is all the effect of the hormones that are secreted. I think I have another table in here as well that shows you the hormones that are produced. Again, the gonadotrophin releasing hormone produced by the hypothalamus, which stimulates the production of luteinizing and follicle stimulating hormones, which will then elevate the luteinizing hormone levels. And instead of producing secondary oocytes, the first meiotic division will then yield a secondary oocyte, which is a small, and then you'll have the non-functional polar bodies that will disintegrate over a period of time as well. At ovulation, the tertiary follicles releases the secondary oocyte, which will then continue to mature. A descended follicle will then rupture, discharging follicular contents, including the secondary oocyte and a surrounding coating of cells referred to as the corona radiculata in the pelvic cavity. And then this empty follicle will disintegrate as well, along with the blood vessels as well. There are other proliferating cells that respond to endocrine secretions, and we see the formation and the degeneration of the cells, or the degeneration of the corpus luteum that was involved in that developing process. Now, hormones are important, as we saw androgens as the primary hormones that were in the male reproductive system. In the female reproductive system, there are hormones that will cause the development of certain characteristics and processes in the female reproductive system. Progestins are one of those. This lipid contained in the corpus luteum is under the effect of steroid hormones known as progestins, typically progesterone, but we'll also see estrogen has an important role here as well. Moderate amounts of estrogen are also secreted in the corpus luteum level, are not high enough as they were in ovulation, and the progesterone is the principal hormone in the interval after ovulation takes place. The primary function is to prepare the uterus for pregnancy by stimulating the maturation of the uterine lining. The lining of the uterus has to be competent to be able to support the developing fetus. What that means is adequate amount of tissue and or blood vessels, blood supply, have to develop inside the uterus or inside the lining of the uterus to be able to support the placenta and or the developing embryo. And we see the primary effect or the function of the uterine lining is under the effect of progesterone. If fertilization and unless fertilization occurs at the corpus luteum, we'll see that this tissue layer will begin to disintegrate or degenerate 12 days after ovulation. Progesterone levels and estrogen levels will then fall markedly. The disintegration and or the involution of the corpus luteum will mark the end of the ovarian cycle. Now, a new ovarian cycle will then begin with the activation of another group of primordial follicles. Again, remember, there's a limited number of these cycles that can take place. Only about 400,000 now remain. And then at a certain stage, again, age being a factor in this, we'll see some of those eggs will begin to degenerate with age and time as well. So many primary follicles have developed into primary follicles. Several primary follicles may have been converted into secondary follicles, and generally only a single oocyte will be released into the pelvic cavity during ovulation. The rest will undergo atresia, or basically eventually will shrink small and then die. At puberty, each ovary contains about 200,000 primary follicles. 40 years later, few, if any, will remain. Only about 500 will have been ovulated during the interim. So a significant decrease in the number of primary follicles that can be involved in fertilization to lead to the development and fertilization to develop an embryo. I talked about and alluded to ovarian cancers before, and I'll bring that back up again. Remembering the location of the ovaries in the female reproductive system. In the United States, we see women 1 in 70 chance of developing ovarian cancer in a lifetime. Again, numbers in your book refer to a 2002 estimated about 23,000 cases of ovarian cancer diagnosed. About 13,000 or 14,000 women die from the condition each year. Although ovarian cancer is the third most common reproductive cancer in women, It's the most dangerous because it's seldom diagnosed in its early stages, and I already talked about why it's not diagnosed early, and it's primarily due to the location of the ovaries. Prognosis is relatively good for cancers that originate general ovarian tissue. These cancers respond well to a combination of chemotherapy, radiation therapy, and surgery. 85% of ovarian cancers develop from the epithelial cells, and a sustained remission can be obtained only in about 1/3 of the cases of that type. The uterine tubes, which are also referred to as the fallopian tubes, are the oviducts, are hollow tubes, hollow muscular tubes, measure about 5 inches in length. Each uterine tube is divided into 3 segments: the infundibulum, the ampulla, and the isthmus. I think that was a test question. Pelvic inflammatory disease is a condition that can affect the reproductive organs, and also we can see this condition can scar the fallopian tubes. And remember, the fallopian tubes are hollow organs, so inflammation decreases the size of the tubes, decreases the opening, or can scar the opening, which would then prevent the release of the eggs from the ovary from being able to pass through the fallopian tubes. And so if you get scarring, that obstructs the ductal system. As you can see, as can occur with pelvic inflammatory disease, it can cause sterility or infertility. An infection in the uterine tubes, pelvic inflammatory disease, estimated in about 850,000 women each year in the United States. Many cases, it's related to sexually transmitted pathogens. 50 to 80% of all cases are due to infection with Neisseria gonorrhea, organism responsible for symptoms of gonorrhea and or sexually transmitted diseases. Invasions in the region by bacteria normally reside in the vagina, can also cause pelvic inflammatory disease. Proximity of the vagina to the rectum, and because of the short urethra, higher incidence of vaginitis and or urinary tract infections and pelvic inflammatory diseases because of the anatomy. Pelvic inflammatory disease, some signs and symptoms. PID includes fever, abdominal pain, elevated white blood cell count. When a person has an infection, whether it's pelvic inflammatory disease, pneumonia, any type of infection, one of the body's responses is to increase leukocytes. Leukocytes are cells that are produced in our bone marrow and basically help fight off infection. Person has an infection, you see an elevation in the white blood cell count. In severe cases, infection can spread to visceral organs and produce generalized peritonitis. Peritonitis, inflammation, infection inside the abdominal cavity, inside the abdominal lining. Pelvic inflammatory disease, sexually active women between the ages of 15 and 24, the highest group. The use of oral contraceptive actually have increased, that says decrease, has increased the risk of infection because it decreased the use of condoms. The presence of intrauterine devices, IUDs, have also increased the risk about 1 to 7 times. Treatment with antibiotic therapy is very appropriate and would respond to most of these types of infections. Recurrent damage, however, recurrent pelvic inflammatory disease, recurrent pelvic inflammatory infections causes scarring within the uterine tube. Again, if you destroy or you damage the inside of the uterine tube, then the eggs can't migrate into the uterus. So it can lead to sterility in these cases. Recently, another sexually transmitted disease, chlamydia, was identified as a probable cause, about 50% of the cases. Also can be treated with antibiotic therapy. Another portion of the female reproductive system is the vagina, an elastic muscular tube extending between the cervix and the vestibule, small space produced by, or in a space bounded by the female external genitalia. Vagina averages about 3 to 3.5 inches, highly distensible, so its size may vary. At the proximal end of the vagina is the cervix. Proximal end is the cervix. Distal end is in the out to the environment. Proximal end is at the cervix. The cervix projects into the vaginal canal, and as I talked about with the pelvic exam, the vaginal walls are opened, and you can visualize the cervix, again, which is the distal portion of the uterus, but at the proximal end of the vagina. Vagina has 3 major functions. Serves as a passageway for elimination of menstrual fluid, It receives the penis during sexual intercourse, holds the spermatozoa prior to their passage into the uterus, and it forms the inferior portion of the birth canal through which the fetus will pass during delivery. Cross-sectional view, section taken out. And again, I just remind you that during the pelvic exam, again, cells are taken from the cervix. A brush is then passed into the uterus. Samples are taken from inside the uterine lining. But remember, this is the pelvic examination has its limitations. If you take a brush sample of cells from the inside the uterine lining, if a cancer is developed here at the proximal end of the uterus, just below the tubes, even the pelvic exam may miss the development of that cancer. And then we've already talked about the limitations in a pelvic exam for being able to screen the ovaries, which is outside of this direct visualization and also very difficult to palpate an exam. But that just helps you to identify the tissue. Now, inside the vaginal canal are normal bacteria. It's normal for bacteria to exist inside the vagina. Vagina is an opening to the external environment. Contains a population of what's referred to as normal flora. If you take microbiology, we also refer to it as normal microbiota. But basically, these are normal bacteria that should be in this environment. There are good bacteria that actually compete for the same nutrient source as the bad bacteria. So in the absence of good bacteria, then you'll get then you can have the potential for opportunistic infections. So the vagina contains a population of resident bacteria, usually harmless, supported by nutrients in the cervical mucus. Metabolic activity of the bacteria creates an acidic environment which restricts the growth of many pathogens. So that's a good thing. But also remember that acidic environment will inhibit the motility of sperm, and so sperm has to produce an alkaline type of secretion. Another process referred to as vaginitis is inflammation in the vaginal canal caused by fungus, bacteria, and parasites. If you take antibiotic therapy, female, you take antibiotic therapy for a short course or even for a prolonged period of time, you kill bacteria. You kill the normal bacteria in the vagina and opportunistic infections can grow. The most common opportunistic infection in women on antibiotic therapy are candidiasis infections or candida or yeast infections. Yeast will grow in the absence of the normal bacteria. Yeast would be able to grow and lead to these types of infections. If the normal bacteria flora was in the vagina, then the yeast would not be able to grow. And again, yeast infections are easily treated with either oral antifungal therapy or topically applied antifungal therapy. But again, it's a result of the absence of the normal bacteria, typically as a result of the absence of the normal bacteria. In addition to discomfort that may result from conditions, may affect the survival of sperm and thereby reduce fertility. This is an illustration from your book demonstrating the external genitalia, structures that you should be able to identify on this picture, starting with the mons pubis, the prepuce of the clitoris. Should be able to identify the glands of the clitoris comparable to the glands of the penis, the labia minora and the labia majora, the vestibule and the hymen and the labia majoris. The external genitalia, again, the vagina opens into the vestibule. It's a space bounded by small folds known as the labia minora. There are periurethral glands or skiing glands which discharge into the urethra near the external urethral opening. Anterior to the small opening of the clitoris projects into the vestibule. A small rounded tissue projection referred to as clitoris, equivalent to the male penis, derived from the same embryonic structure but obviously did not develop as in the male. Clitoris in female equivalent to the penis, derived from the same embryonic structure internally, contains erectile tissue comparable to the corpora cavernosa. I think that's a test question. Erectile tissue comparable to corpora cavernosa. I'm almost sure it is. Clitoris engorges with blood during sexual arousal. A small erectile gland sits atop. Extensions of the labia minora encircle the body of the clitoris, forming the prepuce or the hood. Now remember, the prepuce in the male is referred to as a foreskin. So there are comparable structures here. Now, Bartholin's gland, during sexual arousal, there are periducts that discharge secretions greater than the vestibular glands, the Bartholin glands into the vestibule near the posterior lateral margin of the vaginal entrance. These mucus glands have the same embryonic origins as the bulbourethral glands in males. The mons pubis and the labia majora, already showed you in the illustration. Outer limits of the vulva are established by the mons pubis and the labia majora. The bulge of the mons pubis is created by adipose tissue deep to the skin, anterior to the pubis symphysis. Adipose tissue also accumulates within the labia majora. There are prominent folds of the skin that encircle and partially conceal the labia minora and adjacent structure. Now, another part of the female reproductive system, take that back, another part that we see involved in reproduction, but not a part of the reproductive system, is the mammary glands. The mammary glands are actually a part of the integumentary system and not a part of the reproductive system, a key point. But we're bringing this up because once the egg has been fertilized by the sperm, the uterus has started to respond to variations in hormones, and we start to see the development of the embryo in the womb. We also see secondary characteristics develop in the mammary glands of females. And so it's important that you understand and identify these structures as well. In the last few minutes here of the lecture, I'll go over this. Again, this is an illustration out of your textbook demonstrating to you some of the anatomical features of the breast, the areola, or the heavily pigmented area around the nipple, the lactiferous ducts, lobes of the mammary glands, suspensory ligaments which are involved in supporting the breast tissue, lactiferous sinuses which are open tubular structures which will provide milk to the baby once it's born. The newborn infant cannot fend for itself, and so several key systems are yet to be completed during the development. Over the initial period of adjustment is an independent existence. The infant gains nourishment from milk secreted by the maternal mammary glands. Milk production or lactation occurs in these glands. In females, mammary glands are specialized organs of the integumentary system, not the reproductive system, that are controlled mainly by hormones of the reproductive system, by the placenta, and a temporary structure that provides support of the embryo or fetus and nutrients. Each breast bears a nipple, a small conical projection where the ducts entering from the mammary gland will open to the body surface. A reddish-brown pigmented area around each nipple is referred to as the areola. A large sebaceous gland deep to the areola surface, which gives its grainy texture. The ducts leaving from the lobules converge, giving rise to a single lactiferous duct on each lobe. Near the nipple, the lactiferous ducts enlarges, forming an expanded chamber called the lactiferous sinus. Typically, 15 to 20 lactiferous sinuses open onto the surface of each nipple. Now, here is the illustration that just demonstrates to you, again, comparatively, I showed you one similar to the male reproductive system, where you see the hypothalamus secretes gonadotrophin-releasing hormones, which will then stimulate the production of follicle-stimulating hormones, luteinizing hormones, which will then lead to specific reactions inside the ovaries. As you can see, follicle-stimulating hormones, developing follicles, secretion of inhibin, secretion of estrogen. We see eventually the secretion of progesterone by the corpus luteum. You can see the process of negative feedback from progesterone, which will go back and shut off the production of gonadotrophin-releasing hormone, thus will stop its stimulation onto the anterior pituitary gland, and then the production of or secretion of inhibin, which will cause negative feedback and shut off at least follicle-stimulating hormone. Now, the difference that you see here and what you saw in the male reproductive system, if you remember, luteinizing hormone and follicle-stimulating hormone and its effect on the testicle can both stimulate the production of inhibin, which can cause negative feedback, both of which can go back to the level of the hypothalamus. Here you only see inhibin going back and causing negative feedback at the level of the anterior pituitary gland on follicle-stimulating hormone, and progesterone is what will go back and feedback and block on the hypothalamus. So two difference. And then the stimulation of and its effects on the central nervous system, bones, muscle growth, establish and maintenance of female secondary sexual characteristics, maintenance of accessory glands, and stimulation of endometrial growth. So if you know those two tables, you'd be able to answer any hormone question, primarily where the hormones are produced at, and simply elementary what a basic effect would be on the targeted organs, whether that's the testicles or the ovaries. So those two illustrations, and I